Hello, Professor and my classmates. This is Kamaljeet Kaur. Today I'm going to present my oral case presentation on pneumonia. My client's initial is RJ. He is 70 years old, male, white patient. His date of birth is 12/10/1953. He has insurance of Blue Shield. Marital status is married. RJ came to the clinic accompanied by his wife, who appears to be a reliable historian. Subjective chief complaints: chest pain in the right side when taking deep breaths and coughing for the past 6 days. HPI: RJ is a 70-year-old white male patient who comes with his wife and complains of cough and chest pain when taking deep breaths for the past 6 days. According to the patient, the cough started as an irritating cough in morning and evening, which he thought was an allergic reaction, but has gradually worsened to a persistent cough in the past 2 days. RJ states that the cough has significantly worsened and he often wakes up 2 to 3 times at a night, coughing and having chest pain on the right side. Last night, RJ reported that the area where he felt the pain while coughing now hurts when taking deep breaths. Additionally, RJ reports feeling tired in the past 3 days and cannot keep up with his mates during evening runs. RJ's wife reports that her husband often wakes up with fever, sweating, and shaking chills, and she must cool off with a cold piece of cloth. RJ's wife also reports that over the counter cough syrup and pain relievers have not relieved the complaints. RJ has no allergies or underlying chronic respiratory conditions. Past medical history: RJ has no major chronic condition. He is up to date with all his childhood immunizations. The last flu vaccine was 5 months ago. COVID vaccination is up to date. Surgeries: appendectomy at the age of 25. Hospitalizations once following after appendectomy. Allergies: no drug or food allergies. Current medications: he's taking over the counter syrups for the cough. Family history: his father died due to hypertension at hyperlipidemia at the age of 67. Mother is alive, age 94, with no major medical conditions apart from myopia, corrected with glasses. RJ has 4 siblings, all alive, with the youngest having bipolar disorder. RJ has 3 children, all healthy and married. Social history: RJ is married with 3 children and lives with his wife. He is the second born in a family of 4. Occupation: he worked as a truck driver for more than 30 years before retiring at the age of 61 and currently helps his wife in his grocery store. He denies any form of abuse while growing up. Sexual history: patient is not sexually active at present. Chemical history, like tobacco, alcohol: he denies tobacco, alcohol, or any illegal drug use. Spiritual affiliation: RJ is a Christian and goes to the church every Sunday with his wife. He exercises regularly every evening with his friends. RJ eats a balanced diet of food cooked at his home. ROS: constitutional. Patient reports fever, chills, night sweats, and decreased energy, but denies recent weight gain or loss. Eyes: denies any visual changes. ENT: he denies any hearing loss. Ear pain, tinnitus: he denies any nasal congestion. He denies any voice hoarseness or any sore throat. Cardiovascular: he denies any arrhythmias or palpitations but report chest pain due to coughing. Pulmonary: he reports coughing with no phlegm production and pain in the deep breathing. He denies wheezing or shortness of breath except on exertion, like when taking his evening run. Gastrointestinal: denies any heartburn, nausea, vomiting. Genitourinary: he denies any dysuria and urine incontinence. Musculoskeletal: reports light muscle weakness 2 days ago. Neurological: denies any dizziness, headache, or migraine. Psychiatric: denies any anxiety, suicidal thoughts, any depression, or any sleeping disorders. Endocrine: denies any polydipsia, polyuria, heat or cold intolerance, or excessive sweating. Hematological: no history of easy bruising or enlarged or any tender lymph nodes. Allergic or immunological: no history of allergies or any known genetic immune disorders. Objectives: he has vital signs of blood pressure 124/69, heart rate 88, temperature 99.8, respiration 23, SpO2 95 percent on room air, height 5 feet 4 inches, weight 181.3 pounds, BMI 29.1, which is considered overweight. In my physical exam, the patient looks well nourished, dressed appropriately, and did not look in any acute distress. HEENT: the head is symmetrical, no visible injuries. Perla is positive to red reflex. Sclera and conjunctival is clear. Ears are normal and no auditory canal problems. And nose, there's no deviation in the nasal septum. Throat is moist and There is no swelling of the tonsils. Neurological patient is alert and oriented and normal gait and erect posture. Heart is S1 and S2 are normal. Capillary refills in 2 seconds. No extra sounds noted. Lungs are clear on auscultation. No wheezes. With symmetrical chest wall reports. Chest pain during coughing and deep breathing. Asymmetrical dullness over the right side of the back and symmetrical tactile parameters were noted. Abdomen, no tenderness or abdominal swelling. Bowel sounds are present in all 4 quadrants. Musculoskeletal full range of motion in all extremities, no joint or limb deformities. Muscle power is 5 in 5 by 5, 5 out of 5. In all muscle groups, lymphatic, no enlarged lymph nodes noted. And my assessment in this, I got like my differentials are pneumonia unspecified. My rational, it is like most likely due to the evidence by coughing, chest pain, or deep breaths, fever, chills, and night sweat, which are typical signs and symptoms of pneumonia. Elevated WBCs indicate and sign of infection, further confirming pneumonia as a primary diagnosis. Now, my next differential is COPD with acute exacerbation. The rationale, it is probably due to with the pertinent positives such as worsening cough, difficulty taking deep breaths due to chest pain, tiredness, and shortness of breath on exertion. However, a possible diagnosis of COPD exacerbation is ruled out by lack of wheezing and increased expectoration, which are common in COPD. Next is unspecified asthma with acute exacerbation. The rationale is behind is another possible diagnosis for RJ due to worsening symptoms of shortness of breath and coughing, but it is ruled out by a lack of history of asthma and typical signs and symptoms of asthma like wheezing, chest tightness, and increased pulse rate. Heart failure, it is a possible diagnosis since patient presents with fatigue, shortness of breath with activity, a cough that does not go away, and reduced ability to exercise. However, RJ does not present with swelling in the legs, ankles, feet, and belly area, rapid heartbeat, and wheezing, which are typical manifestations of heart failure. My plan is like standard diagnostic test, COVID test, influenza swab test, chest x-rays, blood tests like CBC, CRP, ESR, sputum culture and gram stain, blood culture, ABGs, and pulse oximetry, bronchoscopy, CT scan, urine antigen test, pleural fluid analysis, and serological test. Treatment, amoxicillin, clavulanic acid 625, POBID for 7 days, and ibuprofen 400 milligrams PO every 4 to 6 hours for pain and fever if needed, supplemental oxygen. Education given to the patient to be compliance with the medication and need to stay hydrated and get plenty of rest, take medications as prescribed, have proper hand hygiene, use humidifier to moisten the air to relieve the cough, and follow-up. Patient need a follow-up upon completion of antibiotic therapy to assess response to the treatment and determine if further treatment is required. If patient does not respond to treatment, a sputum culture might be necessary to identify the causative agent. Thank you so much.